I think that it's a huge question. There are going to be multiple areas at the meeting that are going to be of incredible interest. Number one, there will be incredible interest on maintenance and certification. That winds up being a really important thing going forward because we are increasingly focused on lifelong learning. We used to think in the past that you went to medical school, you learned all the things you need to know, and then you went out into practice. It turns out that many of the things that we learned in medical school are either no longer relevant or some of the time are completely wrong. And so it is incumbent upon the medical profession to continue with lifelong learning. And this meeting focuses on lifelong learning. Focuses on lifelong learning by, number one, helping to identify the learner needs. In the past, it used to be that the lecturer went and lectured upon whatever the lecturer wanted to lecture upon, irrespective of what the audience needed to learn. Now we are trying to focus on the fact that we need to identify learner needs and then move towards those learner needs. So that's going to be a terribly important part about this meeting. The second thing is that there is going to be the initial introduction of just-in-time learning technology. So in the past, what we have done is to have guidelines which are very comprehensive, very good documents, but they are so comprehensive that they're books, they're textbooks in and of themselves. And so when you're asked to see a specific patient in the middle of the night, rather than have to read a whole textbook or thumb through a whole textbook, we then have technology that ACC has developed, and Mayo has been very involved with that, that allows those guidelines to be rapidly scanned in time so that you can ask the question and then have guidelines given back to you about what the optimal approach is, either to diagnosis or to treatment. That's the second piece of information. There'll be the chance to interact with the legendary people in the field, the people that we grew up reading their papers, grew up listening to them give lectures, grew up listening to how they focus and really define the fields, and so they will be there, and I'm incredibly excited about that. An important part of this, any of this journey, is late-breaking clinical trials, which are huge. In general, late-breaking clinical trials are headed in very large arenas because so many people want to come, because it's the latest and greatest stuff. There are lots of different caveats in terms of selecting those late-breaking clinical trials, and it's a high mark to get through. And so there are 18 late-breaking clinical trials at this meeting. There are going to be several different groups of them. Obviously, no one knows the answer to those late-breaking clinical trials because that won't be unveiled until next week in Chicago. But incredibly important issues to be addressed will be, number one, comparative effectiveness of patients with angina undergoing coronary revascularization. We still struggle, the profession is still struggle, and patients and healthcare providers struggle with how to select therapy in patients with multivessel disease, whether that be percutaneous intervention or whether that be coronary bypass graft surgery. Are there specific groups of patients that might benefit from one versus the other? Or groups of patients in whom you can do either way, depending upon the patient's interest. Of course, at the very end, the patient makes the decision anyway, but we have to make sure that we give them the information to make the right decision. And so the ASSERT trial, which is going to be a comparative effectiveness trial of several 100,000 patients, will allow an assessment of the comparative effectiveness of coronary surgery versus percutaneous coronary intervention. A second red-hot topic involves the use of stem cells. Stem cells have been around for a while. Cardiology has waited for multi-center randomized trials to see if stem cells given at some point in time during an acute event, whether that be acute myocardial infarction or maybe even congestive heart failure, acute episode of congestive heart failure, whether stem cells, autologous stem cells, could be used to augment contractility of the heart. And so there's a late-breaking clinical trial, actually it's the first late-breaking clinical trial, which will relate to the use of stem cells to see whether they impact in terms of both clinical efficacy, but also improve left ventricular function. There will be studies about how to mechanically, in the catheterization laboratory, restore flow. Are we going to use a specific adjunctive therapy, a specific agent that we've used in the past but we haven't done it systematically? This will allow us to improve on the issue of no reflow during acute myocardial infarction, which continues to bedevil us in the field. There will be information on elective PCI in the setting of non-surgical backup. Although Mayo has done that for some time now, for the rest of the world, for the rest of the United States, it's been a spotty sort of thing, in part because we didn't have as good a data as we'd like. Our experience here at Mayo has been very good, but that has not necessarily been the case everywhere. And so then a final report of the Seaport trial will allow us to look at elective PCI without on-site coronary bypass graft surgery. I think there will be other incredibly interesting topics related to how do we select lipids and lipid-lowering drugs to optimize the long-term outcome of that, and look at some of the important genetics related to that, and look at hypotheses that might affect how patients might respond and which patients then we could benefit by giving them drugs like that. So there are going to be a whole range of topics that are focused on with the late-breaking clinical trials, both in heart failure, both in stem cells, both in percutaneous coronary intervention, both in new drugs, as well as in epidemiology, and finally in imaging. We still don't have the best approach to saying which imaging modality is going to be great. Is it going to be CT? Is that going to replace everything else? What do we do with that? And so there will be a late-breaking clinical trial related to that. So we will cover the broad range in these 18 late-breaking clinical trials.